Welcome, everyone. My name is Rohit Singh. I'm a medical oncologist at the University of Vermont Cancer Center and assistant professor of medicine at the Lawrence College of Medicine. And as I said earlier, I had the honor of serving as a clinical co-chair for this year's conference. It is my pleasure to introduce today's panel facilitator, Dr. Chris Anker. Dr. Anker is a professor in radiation oncology. He serves on the UVM Cancer Center's senior leadership team through his role of co-leader for the Cancer Host Environment Program. He has co-authored over 85 peer-reviewed publications, including 14 national guidelines on how to treat various cancer types. And he has developed and helped bring numerous clinical trials to UVM. He serves as a principal investigator on multiple trials we have at UVM. He is active in the National Research Group, a multi-institutional cooperative research organization, and he's engaged in numerous projects I mentioned with radiation physics. He believes in empowering patients to make treatment decisions that best fit their specific care goals. By working with the rest of the cancer team, his goal is to ensure patients have a thorough discussion to all available treatment options. With that being said, I will hand over to Dr. Chris Anker. Thank you.
Hello, everyone. So I'm really excited about the session today. We got some great speakers here. So Dr. Matthew Kinsey, Dr. Michael Brasino, and Dr. Havaleh Gagne. And kicking things off with Dr. Matt Kinsey. So Dr. Kinsey is an associate professor of medicine in the Larner College of Medicine. And he leads a NIH and industry-funded clinical and translational research program investigating intratumoral therapies for lung cancer. He completed pulmonary and critical care training in Massachusetts General Hospital and interventional pulmonary training in the combined Beth Israel Deaconess Massachusetts General Hospital program. Dr. Kinsey established and directs the interventional pulmonology program at the University of Vermont Medical Center. He's a prior awardee of the UVM Dean's Excellence Award for Junior Investigators and for clinical trials, and he is the 2023 recipient of the Jeffrey McLennan Award for Advancement in the Field of Interventional Pulmonology. So welcome, Dr. Kinsey.
Thanks, Chris, and thanks for the opportunity to speak today. Just really cool turnout. Thank you to the organizers for putting it together, for all your work, Rohit, and Molly's. This is a exciting conference. I've been here a couple of times, and it's a great conference. So I'm going to talk a little bit about some of the work we do, but I also want to take a few minutes and talk a little bit about epidemiology of lung cancer, because I think it's relevant for the things we're going to talk about as part of this panel. These are my disclosures. The only thing that's relevant is I chair the Interventional Oncology External Advisory Board for Johnson & Johnson, and there are a couple of Johnson & Johnson studies in here. I'll try to point those out where they're relevant. So I think particularly relevant to this group and to this conference is an acknowledgement of the impact of lung cancer, particularly on women. And you can see in this chart, these are cancer statistics that are published every year, updated, that cancers of the lung and bronchus are the second most common cause of cancer in both men and women, but by far the leading cause of death, right? So lung cancer has an outsized impact on cancer-related mortality, both in Vermont and across the US. And it has continued to be, I would say, even a greater problem in women than in men, specifically because we haven't seen the same decrease. And that's what these charts are showing you. These are years on the y-axis and the rate of cancer. And as you can see, due to the decline in smoking rates, there's been a larger decrease in lung cancer in men than in women. And now they essentially approach the same overall numbers. But we haven't seen the same drop-off in women as we have in men. Part of that may be due to some of the different sort of genotypes of cancer, some of the causes. I'll tell you, in Vermont, we could talk a lot about lung cancer epidemiology in Vermont, but in Vermont, we have an outsized proportion of lung cancer compared to our smoking rates. So it's a local problem. Melanoma is the other cancer that we have an outsized proportion of in Vermont. And so I think we have some unique facets that drive that disease in our area and across the US. And because of that, mortality associated with lung cancer, there was a lot of interest in developing screening tests to detect it earlier. And so the National Lung Screening Trial was published in 2011. UVM was one of the first centers in the US to stand up a lung cancer screening program, meaning you get a CT scan every year of the lungs to try to identify early cancers. That was driven out of radiology, so they did an incredible job standing that up along with Garth Garrison, who's one of the pulmonologists. And really the take home is if you fit those criteria on the bottom, which is the current US Preventive Services Task Force, you should get a CT scan every year to assess for potential lung cancer and detect it earlier. And it has an impressive reduction in mortality. But one of the other big drivers, I should be careful here, of mortality in lung cancer, and a problem across cancers, in fact, is the difficulty of getting an intravenous drug into the tumor. And you heard a lot about ways, that was part of what the ADC talk was about, delivering drugs without exposing off-target cells in the body, meaning can you just target the drug to the cancer itself, right? So there's a lot of interest in reducing these off-target adverse effects. And a big reason that these occur is because there are high mechanical stresses within a tumor that basically crush those small blood vessels. And so what happens is you only get drug near the outside areas of the tumor. And that's what this photomicrograph is showing here on the right side of the screen. These are tumorlets, and this is a labeled drug in green, and you can see it just accumulates at the edge of the tumor. This is actually from a head and neck cancer, but the same thing happens in lung and a lot of tumors. And in fact, that's one of the drivers for things like oncolytic viruses, like the approved therapy T-VEC for melanoma, right, which is an intratumoral delivery. And we'll talk a little bit about that. We study the delivery of platinum drugs directly into tumors. And as you heard from Rob Cade, who might have talked in the last session if you were here, he was talking about the standard, sort of adverse events that you think about with chemotherapy: nausea, vomiting, hair loss, right? These are platinums, right? Those drugs. There's one of the oldest classes of drugs, active in a lot of different sites of cancer, but a lot of off-target side effects. And what you see when you start digging into side effects is that women are more likely to have side effects regardless of if it's chemotherapy, immunotherapy, or targeted therapies. These are things like EGFR targeted therapies. This is a forest plot on the right-hand side of the screen. And what that shows you is that basically as those bars and diamonds move farther to the right, it shows you a higher probability of having an adverse effect if you're a woman from those same therapies compared to men. And so we know that these off-target adverse effects disproportionately affect women, actually. And it's one of the drivers trying to prevent these off-target effects of why we study intratumoral therapy, right? How do we deliver drugs and biologics directly into a tumor to reduce off-target effects? And our group does that through pulling tissue and imaging data from cases that we do in the OR. This is a robotic bronchoscopy system. This is a CAT scanner, basically, that sits over the patient. We have ultrasounds. We have a number of different techniques for getting those data. Sorry, that used to be a slide. And then we can take the image data and analyze that to try to understand where the best locations are to deliver the drugs. And this is kind of how we iterate and design our clinical trials. This is our clinical trial portfolio. We've completed several phase 1 studies of intratumoral cisplatin. We have a new study that is hopefully going to be funded. We think so, but that I'll talk about briefly in a minute. This is an active study this is not one that we designed, but we're part of, in part because of an institutional expertise in being able to deliver drugs directly into tumors. This is the Converge trial. This is a Johnson & Johnson funded study. It's across 10 centers in the US. It's a phase 2 study. And this is for patients that have stage 3 lung cancer and are going to get chemotherapy and radiation followed by immunotherapy. And the goal, in part because of what I showed you before about how those middle areas of a tumor can be left untreated, that's one of the reasons that we do surgery or radiation, as Dr. Gagne is going to talk to you about, and chemotherapy and immunotherapy, right? That's why it becomes the and. And the goal of this study is to deliver a radio enhancer, basically a drug that's designed to help the radiation therapy work inside the tumor in those areas that are hard to get to with your chemotherapy. And so that's an ongoing trial that we're part of. This is one of the ways that quick slide to show you how we deliver drugs into these things. This is a tumor here in the left upper lobe of the lung, this kind of white spot. This is what we see from that robotic system. Looks like a video game. It is a little bit like a video game, right? Which means that my job's gonna rapidly be obsolete, right? We're gonna hire some kid in a basement to take this over from me. And then here you'll see in the tumor, this is actually the needle here in the midst of the lesion itself. This is the kind of responses that we see. This is a patient that Dr. Anker and I took care of. You can see here, this is a PET scan, a way to label sugar if you're not familiar. Orange, this is a recurrent cancer. We treated that with intratumoral therapy, and the patient had a very good response. Eventually, unfortunately, passed away actually of pneumonia, not of a recurrence of his malignancy. It's one of the things that's a real driver for us to kind of get up early and think about these things is when we see responses and things that make us hopeful. And then this is the sort of the crux of our new study. We believe that it's important where within the tumor you deliver it, and we can use some fancy radiologic techniques. This is a big tumor here that is sitting on the edge of the lesion. I just realized that mouse not showing up there, but right on the right side of the screen. And then as you move over, those green arrows are areas that are relatively deprived of blood vessels, probably a better target to place a drug because you lose less of it in the circulation, versus the red areas, which are high vascular density areas, lots of blood vessels, and the drug's gonna get more likely to get soaked up. And so we treat patients who are coming in and begin the treatment, which is one of the goals of our program, at the same time that we perform diagnosis. So one of the things we're super committed to, both from our research side and then across the lung cancer team, is reducing time from diagnosis to treatment. Anybody who's been through cancer knows that that's one of the hardest times, is when you hear, hey, this could be a cancer, and then followed by, we don't know, we don't know, we don't know, we gotta do this, we gotta do that, we gotta do that. So one of our goals is really to reduce that time. So with there, I'll kind of stop, just a quick overview. We talked about lung cancer's impact, particularly on women. We showed you some of how we can deliver drugs into tumors. And we'll, again, like I mentioned, we do this in a diagnose and treat paradigm. So we try to do it all in one setting. And then again, get screened if you know people, and be a lung cancer advocate. I think lung cancer gets, I think there's bias, quite frankly, towards lung cancer. I think that people feel guilty around having smoked in the past, even though this country had a love affair with cigarettes. This is me editorializing. But I'll say, so, be a lung cancer advocate as well, because it does impact a lot of patients, and particularly women. So with that, I'll stop. Thank you.
All right, thank you, Dr. Kinsey. Yeah, we'll do questions at the end. And, when I first got to Vermont over 11 years ago, I was thinking, who is this guy who wants to inject our patient's lung tumor with some drug? But now look at him. He's an international leader in this novel therapy, and it's really exciting to see how things are homegrown and getting to have such an influence, across the world. And he's just doing some really great work making sure that it has an even improved impact. And just moving on also from what he mentioned about, Dr. Lester Cole's excellent talk on AI this morning and diagnosing lung cancers and screening, and Dr. Kinsey's important comments about, lung cancers might be from smoking, but otherwise. So one thing I get to do besides being the lung team as a clinician is get to be in this, one of the research program co-leaders, and get to see the amazing fundamental science work that's going on. And Dr. Michael Brasino is a key example of that. So originally from outside Seattle, Professor Michael Brasino performed undergraduate research in semiconducting materials and competed in a synthetic biology competition at the University of Washington. These experiences inspired him to pursue a PhD focused on genetically engineered materials at UC San Diego and CU Boulder. He then became a postdoc at the Knight Cancer Institute in Portland, Oregon, where he began to build and characterize genetically engineered probiotic bacteria as cancer-detecting probes. Since August 2024, he has been expanding on this work in his bacterial biosensors lab at the University of Vermont. So, welcome, Dr. Brasino.
Oh, good, it's all synced up. So yeah, if you thought injecting lung tumors was weird, just get ready for this. As Dr. Kinsey wonderfully motivated, there's a big need for detecting lung cancer earlier because it saves lives. Something that we think about a lot is not just how specific and sensitive can we make new screening technology, but how convenient can we make it. One thing that is pointed out regularly about low-dose CT scans is that very few people actually do it. And so a big focus of my lab is building screening technology that people are more likely to do. While it may sound strange, we think that genetically engineered bacteria are a way to do that. So our vision for how this screening technology would work would look something like this. You would take bacteria, probiotic bacteria that are regularly used in yogurt production and other food products, things that people are already consuming regularly, and genetically tweak them so that they could detect certain markers from a tumor. People who are then at risk of developing lung cancer could inhale these bacteria with a nebulizer type device, possibly at home. And then once in their lungs, those bacteria would sense markers of a tumor and in return secrete molecules that are more easily detectable. So in that way, the bacteria are converting a very small localized signal found only in the lung into something that we could detect possibly in urine. And so this technology might make it so that we can move from LDCT scans and other technology that requires travel and complicated machinery to something that you could even do at home as easily as a pregnancy test. So I'm going to be talking about developing this technology, and I'm going to use the term in vivo. And when I say that, I mean just in mice. We're only working in mice. Mice aren't little people, but they're the closest thing we have. Just all of this data is going to be pretty preliminary in comparison to some of the other talks. To start this out, we needed to choose what type of bacteria to use to build our biosensor probes out of. And we chose Lactobacillus plantarum WCFS1. This is a probiotic strain of bacteria. It was originally isolated from the saliva of a healthy human child. And it's been sold as a probiotic over the counter in Europe and the US for decades. So that means that there's this long history of safe consumption by a large number of individuals. More importantly, or equally important, there was also ways of genetically modifying it that had already been developed. And so we can make genetic tweaks to this that are stable, that don't change over time, that aren't going to be shared between bacteria, which bacteria sometimes like to share DNA with each other. And so there's a lot of tools already developed for this that can make these genetic modifications stable and contained within our bacteria. The first thing we did with these genetic modifications is make the bacteria easily trackable so we could see what would happen if we administered it to the lungs. And again, we did this in mice. So specifically, we made the bacteria glow. We gave it a gene for luciferase, much like the genes that are found in fireflies, and that made it glow under certain conditions. We could then administer it to mouse's lungs, as shown here, and then under the right conditions, get it to bioluminesce. And then we put the mouse into a little dark box with a camera on top, and then we could image where our bacteria were going in the animal based off of where we saw kind of a faint glow. And the camera is much more sensitive than yours or eyes, so it can pick up some of these faint signals. And what we saw was that first our administration worked. We could get bacteria directly into the lungs, that the bacteria would stay there in the lungs. They don't move around, which would be unideal. And that they don't colonize. We don't see engraftment, as other people call it. So we don't get bacteria that are going to grow anywhere else in the organism. And so this is all these are all the features of a biosensor probe that we'd like. Something that's temporary, something that goes right where we put it, and that sticks around long enough potentially to sense something and send out a signal in response. So once we knew that we had bacteria that we could put down into the lungs, we wanted to see, can we get a signal out from it? So to do this in mice, we did another genetic tweak. We made our bacteria constantly secrete another molecule called nanoluciferase, or NLUC. This is another bioluminescent enzyme, but it's not easily detected inside a living organism, but it is really easily detectable in urine. And so if we administered these bacteria that were secreting nanoluciferase to mouse lungs, we could then collect the mouse's urine over time, over the next several hours after our administration, and we could check for the amount of nanoluciferase in their urine. And what was nice is we could see that if we gave the mouse more of our bacteria that were secreting this enzyme, we saw more signal in the mouse's urine over time. So that indicated that not only can we put bacteria down there, but we can actually get a signal out. We could also see signal in the mouse's urine at the same times that we knew that the bacteria were remaining in the lungs. So that gave us some confidence that our signal was coming out of the lungs from the bacteria while they're still there. But next we wanted to know, are the bacteria just being destroyed in the lungs, getting cleared away by like all the other bacteria that we normally breathe in on a day-to-day basis are, getting eaten up by your immune system, and then the nanoluciferase is floating away, or are they actually able to do something when they're down there? Can they remain responsive, essentially? So to test for that, we made yet another strain of bacteria. This one would only release that nanoluciferase, that urinary enzyme, when the bacteria were around a specific type of sugar molecule called xylose. Now, xylose isn't metabolized either by bacteria or by mice, so it doesn't do anything else. But the bacteria can sense it, and they know to turn on nanoluciferase expression just when that's around. And so we repeated our experiment, administering our bacteria with or without xylose. So with xylose shown in light blue and without xylose shown in purple. And we could see that we got increased nanoluciferase expression or a signal in the urine of mice that had been given the xylose along with the bacteria. So this was our first indication that our bacteria aren't just there dying in the lungs of the mice and not able to sense anything. They can actually remain responsive when they're down there, and maybe they can get something done. So what we'd like them to do is, of course, detect a tumor when it's down there. And I'd love to tell you that we can detect real tumors down there in the lungs of mice. We're not there yet. We cheated a little bit and created a fake mouse tumor. And when I say we cheated, I mean that we tweaked the mouse tumor itself a little bit. Specifically, we made it secrete a small peptide, just a small molecule that we already knew that we could get our bacteria to detect. So this is, again, just to show a proof of concept, essentially, just to see that we can detect some type of tumor in mice and that the whole system works all together. So first, we wanted to make sure, can our bacteria sense that peptide? So we tested various concentrations of this pure peptide, and indeed it could detect very, very low concentrations of that peptide just in pure form. And then we showed that we could take the cells, the tumor cells themselves, and then when we mixed those with the bacteria, it would turn on nanoluciferase expression in response. So next we wanted to see, can this all work in vivo? We have this fake detection system for the tumor, but can we create tumors from those lung cancer cells and have our bacteria sense them in living mice? So to do that, we implanted our tumor cells into the lungs of mice, allowed those to develop into tumors, and then we administered our bacteria on top of those. And we saw increased nanoluciferase expression in the urine of mice that had tumors in their lungs as opposed to mice that didn't have tumors in the lungs. So altogether, we could detect a very engineered or fake tumor in the lungs of these mice. So the focus of my lab currently is how to move any of this out of mice and more toward people. So there's a lot of things that we're doing that don't necessarily translate into clinical practice. We're pipetting our bacteria pretty much directly into the lungs of mice. We're obviously not going to do that with people. We're detecting a fake peptide that we've made our lung tumor cells produce. So we need to actually get our bacteria to detect real markers that a lung cancer would create. And we need new ways for our bacteria to respond to a tumor, new signals for them to make that we can more easily detect in human urine. And so I don't have the answers to all of this, but I want to talk about two projects that we're working on that address some of these. First is, how might we detect a real lung tumor in people? So lung adenocarcinoma, which is one of the more common forms of non-small cell lung cancer, generally leads to an increased protease activity, specifically a molecule called MMP13. And that protease can chew up specific protein sequences. And we've worked out a way for our bacteria to sense the presence of that specific protease in its surroundings and increase nanoluciferase expression in response. And so while this is still just in a test tube, we're moving that toward more real applications. Another idea that we've had is for how our bacteria are going to create a signal in human urine. And what we're thinking in regards to that is to use real pregnancy tests. So HCG beta is the molecule that's normally detected to indicate early pregnancy. It's what is detected on an early pregnancy test. And most people that are at risk of developing lung cancer aren't at risk of being pregnant. Or at the very least could easily differentiate between a test that's indicating whether they have cancer or a test that indicates that they're pregnant. And so what we've done so far in the lab is get our bacteria to produce that same molecule, HCG beta, and secrete it into its environment. And we found that if we just take a little bit of the bacteria and their growth media and we put it onto this early pregnancy test, we can get it to test positive as opposed to bacteria on their own. And so we're thinking maybe we can just use a real pregnancy test at the end of the day for this. All right, so these are just some of the early work that's going on in my lab in regards to all of this. Happy to be here.
Yeah, some clearly out-of-the-box thinking there from Professor Brasino. So really, really exciting stuff, and very relevant to our catchment area, where it's rural, it's hard to get places. We can't send a CT scanner to everyone's home, but this could be something much more accessible, and hopefully it continues to progress and pan out. All right, so we diagnosed these lung cancers, screen for them, and so how do we treat them? So Dr. Gagne is going to speak more to this. Dr. Gagne is a clinical professor of radiology and radiation oncologist at the Lerner College of Medicine and practiced at UVMMC since 2008. Her clinical interests include treating cancer with vintage model patients. Some might use the term geriatric, and with healthy aging. She recently earned board certification in clinical informatics. She was among the first radiation oncologists in the nation to be trained to deliver stereotactic radiation therapy to the lung. Actually, one of her mentor was really the person who, we would say, invented the whole process. And so really exciting to have her in our department helping push things forward, and we're all always learning from her and how to do things more effectively and efficiently. So, Dr. Gagne, looking forward to talk.
Okay, well, thank you so much for the introduction, and thank you for having us here and hosting us for this panel. I think there's some really exciting things that we can do for patients that we're doing now and that are on the horizon. So my talk will be on stereotactic ablative radiation, otherwise known as SABR. So I'm going to start with the things I hope that you'll learn from this talk, my key takeaways. Think about SABR like surgery. It eliminates tissue in a small area. One of the proprietary named machines that deliver this type of treatment is called the SABR knife. So we really try to think about it in the same way we might think about surgery. It can be used to cure cancer. We use radiation for a lot of things, but we actually can use it to cure cancer, and particularly in lung cancer, we can do a pretty good job. We also use it to spot weld tumors. So if there's like a little spot here or there that's causing problems, we can take care of that too. And ultimately, it's really a powerful tool in your toolbox. So these are the things that I hope you'll take away from this. To start out, what is stereotactic radiation? It's a high dose of radiation. It's given in 5 or fewer treatments. The targets are fairly small. They're about up to 5 centimeters in diameter, so it's bigger than a golf ball, but smaller than a baseball. We can treat tumors in lung, bone, adrenal glands, even in the brain. There's a variation that can be in the brain, the liver, and the kidney. And we can use, and also with this, we use imaging to precisely plan and administer the treatment. When would we use stereotactic radiation? One of the first indications was to treat really small lung cancers for cure, and this is an excellent alternative to surgery. We use this when there's a really small number of metastatic sites. So for patients, and this can be of patients who have metastatic lung cancer or other types of cancers, if they're on a certain treatment and everything is going well, except there's like one little spot that's causing problems, we can take care of that spot, and then they can stay on their treatment that is working for them otherwise and that they're tolerating really well. And generally, in the areas that we use this technique, it's a greater than 90% cure rate, and particularly in treating primary lung cancers. If you went to Vegas with those odds, you would have a really, really good time. It works pretty well. The patient experience of radiation, it's about a 30-minute treatment, and it's 1 to 5 painless treatments. This is a picture of a linear accelerator. You lay on the table, and the machine moves around you. It's not super loud. It's not super close. People don't usually have problems if they have claustrophobia, but I will say the therapists that administer the treatment are super nice. And I'm not just saying it because there's a few here today. They really are super nice. And what I love about this treatment, and it's given with the same machines that we use every day. These are the workhorses of delivering radiation therapy, which means that this treatment can be delivered in rural clinics as well as more urban ones. And I just love that there's more accessibility for patients, and particularly for our state, I love this. So this treatment can be delivered at Central Vermont. You can get it in Plattsburgh. You can get it here. You can also get it in Rutland. And so again, that's one of the things I've always loved about this treatment. The other parts of the patient experience with this kind of treatment are some side effects. And patients can have scarring to the area of lung that we treat. They can have shortness of breath, and that really varies in part for what your baseline lung function is. And I will say that this treatment was originally delivered for patients who had pretty severe lung problems and were not able to have surgery. So there's a handful of patients that I wouldn't offer it to, but most patients, even if you don't have great lungs, you can usually have this treatment. Patients can get rib fracture and tiredness, and rarely can we collapse a lung. It does happen, but not very often. The side effects really are usually mild to moderate, and truly patients tolerate this really, really well. Sometimes they don't have any side effects, and they're just shocked when they come in for their follow-up visits, actually feeling really good. And sometimes there are more severe side effects. And really the side effects depend on exactly where we're treating, so you would need to speak to your particular doctor, and they would explain to you exactly what you would have for side effects. Really, the position in the lung really will determine it, and you would get a good idea of that from a visit. So here's a couple of cases that I made up. This is not any one particular person. This is something I made up from treating lots of patients. So our first patient is a 75-year-old woman. She has some breathing problems with COPD and emphysema, but overall, she loves her life. She likes dancing, and she likes being in her garden. She's pretty happy. She is worried that she would have a hard time recovering from surgery and anesthesia if she had a surgery. So we decided to treat her with a stereotactic radiation. She does pretty well with it. Afterwards, she is a little bit short of breath. She had some scar tissue, but she can still do most of what she wants to do. She did get a rib fracture from the radiation, and it hurt, and she healed from it. We always would continue to follow patients after they're treated, usually with a CAT scan about every 6 months. And in her case, on a future CAT scan, we have found another spot on the opposite lung. And since she did pretty well with the first treatment, we went ahead and decided to treat on the other side. This situation has come up fairly often, and I've treated a number of patients 3 or 4 times. It depends on each situation, but we can continue to treat patients, and that's a common question I get. Can I get this again? Sometimes you can. We take it case by case, but sometimes you can. So the next case study I wanted to point out is the next patient has a metastatic lung cancer. She's been treated with immunotherapy, She has one small spot on a bone in the spine that's growing, and the rest of her disease is really controlled, and she's really feeling pretty good on her treatment. She can do the things she wants to do. She can go travel. She's having a good life. So we decided to treat her with stereotactic radiation as well, and she continues on with her same drug. And I didn't describe the pictures as much, but in the picture you can see like the black and white is the CAT scan, and the little colored with this concentric circles is the target area, and it's a really pretty small area compared to the rest of the body. Special considerations for women. Rib fracture is more common in women, and we think it's because more women will have osteoporosis underlying when they come in for treatment. About 17% of all patients who are treated with radiation can get a rib fracture. It doesn't mean that they are all having terrible rib pain. Only about 5% of patients will have mild to moderate chest wall pain, in part due to rib fracture. It's hard to believe, but it's true. Sometimes we find rib fractures on the scans and that patients actually haven't had pain with them, and they've been doing pretty well. And when we compare women to men, we estimate that women have twice the rib fracture risk as men. So back to my key takeaways. Really, we like to think about stereotactic in terms of like surgery. We have a tiny little spot. We need to take care of it. And we can use radiation for that. We can ablate it. That's why it's in the name. We can definitely use this to cure cancer. It has a good track record. We can use it to spot weld, like little metastatic spots. And it's a powerful tool in your toolbox.
All right, thank you, Dr. Gagne. So yes, we're really excited to have options for our patients, whether or not they can go to surgery. You know, this radiation has been working out very well for many people. So all right, time for some questions.
I had a friend, a fairly young female friend, who came down with lung cancer, which seems to be a new issue. And in being treated with radiation, she ended up with a hole in her esophagus and ultimately died from the bacteria they could not treat. How common is that?
For this kind of treatment, I would say that's pretty uncommon. The esophagus is a very sensitive organ to radiation, and it's one that we look at and take into account when we do the planning. As I described, we use imaging to plan it out, and so we do a CAT scan to begin with, we mark out all the organs, and then we use computer modeling to model out the radiation, and we do try to avoid treating the esophagus. I've definitely seen patients who do get some irritation to the esophagus, but I've not seen something quite that severe with this particular treatment. I think that would be extremely rare.
As a breast cancer survivor, I get screened every 6 months with alternating mammogram, January each year, remaining breast, an MRI of chest, July each year. We know that a likely place of metastases is to the lungs. Do you recommend another form of screening, and how often?
Okay. I think screening is a really complicated sort of procedure to think about, and I don't think we would usually screen in the lungs. Frequently, depending on a patient's certain situation, they may be getting a CAT scan of the chest, abdomen, pelvis intermittently, and that's a pretty common way to follow certain patients. It's something that's very individual, and I don't know that there's a standard guideline for it. And usually screening in particular comes with more standardized guidelines based on some more data. So I think that at this time, that would be more of a case-by-case situation.
Anything else? Anything online? All set? All right. Well, thank you everyone for your attention today. Appreciate the opportunity to talk.